just throw it out. How specifically, because God, we would love to know, how are you going to get those kids in that demographics, not just improving them, but you're going to get those kids 2% higher than the district average, which includes Pineview.
Right. So I think that the goal was 2%. Then I think it said then the local district
No, it
schools.
says the district.
Okay, because I know for sure when we talked about it, we said, here's a school that if it's approved in this particular area, it's going to have an imbalance to it. It might draw some students from South Sarasota, and it might draw some students from the southern part of Manatee County, and it's designed to serve a more at-risk population. So if you were to take those three combinations, the overall school performance grade is going to be probably lower than the overall Sarasota County school demographic.
I expect that, but your application says something else.
So I apologize if in the application and in where it asks for clarification in the rubric, the conversations we already had is to clarify not higher than the whole district, but to higher than the local district schools in which those students that we draw from are coming from. And I do think that that's a fair goal to say that in this particular area, for the schools that are not performing as high as Pineview, Sarasota Middle, some of these other local schools, that it would be better. And I'd rather be able to clarify that and to say the goal is not to be 2 or 3% higher than the overall district average, but to be higher than the schools in which the students come from.
Because from my perspective in Sarasota County, I mean, my son
can't get much higher than Sarasota County.
I agree. So my kid comes home and he brings his report card. I call it the Spanish report card. It's CCC, and he's trying to tell me that that's average, and I have to tell him no. So in Sarasota County, having I was born in Cuba, so I feel fine. I can say that. So I don't have a problem sending flights down to Cuba. But my issue is having a C school. That is not that's a school that we need to look at and needs to be improved if in Sarasota County.
Right.
Other districts may view a C school as that's okay. We need to do triage on the D and F schools.
Right.
In Sarasota County, our C schools are not, and so I have so many concerns about independence, knowledge, financial, your knowledge of your application, knowledge of the schools you're at. I mean, I'm going to run out of fingers soon. So I have grave concerns about that issue. About the fact that you guys have in other districts, you guys are C schools.
Right.
Because
so
I want you to come here.
Very different.
I want you to come here and be an A school. But your track record doesn't show me that.
Well, our track record right now is the schools that we're at in Hollywood and Hillsborough County that just opened. So there's nothing to even really rate or judge that by, other than the schools that we have independently run. In Hollywood, the demographics are drastically different than the schools that we're talking about here, and we don't want to be a C
I was talking about
either.
schools that Jennifer, Frank, and Justin are involved in.
Right.
I wasn't talking about this entity overall.
Right.
You do not have in our district. We are an A district, and we have a track record of excellence. We want to continue that. Right. You have a track record of not A for excellence.
Right.
So again, I'm gonna run out of fingers.
Okay.
You're not giving me a level of comfort. Please give me a level of comfort. My time's gonna be limited. Give me a level of comfort. You've heard my concerns go round and around. I think I've been pretty consistent. Make me feel better.
So my goal is to be the A as well. I can tell you what the growth was in Hollywood, that we were 2 points away from a B, and it does matter that we're working specifically on those subgroups, because we would have a different type of a bifurcated group here as well. In Hollywood, it will probably qualify this year as a Title I school, and being a Title I school with I think 1,400 kids and 2 points away from a B in the K-8, we've done a lot of growth there. I would expect for both of those campuses to be a B school, and by year 4 push up towards an A school. And those are lofty goals when you have a Title I school and 33% ESOL population, which is what it has there. I will tell you, I understand what some of your concerns are. My whole goal is to be in the school, on the ground, and to be able to work with those subgroups, and you work on growth, and eventually you get to where you need to be. I do not think that the school is going to open up specifically serving that area in the north part of Sarasota and outperform all the Sarasota district schools. But what I do believe is that with the right leadership there and the right support there, that those kids have an opportunity to also be in an A school and to have equity and access that they may not have already, and that our program with an extended learning day built in for interventions and acceleration for some of those kids that need it, and the after-school program, is that we are going to move
But
those
I
kids.
agree that, I don't know how much time I have. I agree our kids have opportunity opportunity for A school, but they have the
Right.
opportunity from A school
Right.
on our district managed schools. They do such
Right.
a wonderful job. They already have that opportunity. You got to show me. You can give them more of an opportunity.
So we have to have the opportunity to do it in order to show you that we can do it.
Jane?
Being passionate about it.
I know. Jane?
I want to validate a couple of things. You mentioned ninth grade in your handbook. Are you thinking of moving into high school? Are you?
No, we were showing draft handbooks.
So that
because
was
it's a draft.
Broward's handbook with just some boilerplate. You mentioned 90% retention in the second year that of the students that you had enrolled in the first year, which I think your enrollment numbers are a little lofty. But in the second year, that 90% would return. Why?
So that's pretty standard in a public school of choice, at least in my experience, because especially in the early years, the first 3 years, you're kind of defining who you are, and then also the community's getting a better appreciation of what you stand for. So after that first year, a lot of families, well, not a lot, but a small number move, and then some say this wasn't really what we thought it would be, and then you have a little bit of transition. So 90% retention would probably be really good after the first year, in my opinion.
I'm concerned about a couple of things. Looking at the preliminary ratings that we had, 11% meets an educational plan, our total preliminary total of 26% meets. But I would like some more definition of this professional development in particular, Jennifer, if that's possible. I don't see partners doing professional development as purely as maybe I'm talking about it. So I would like some explanation at the next phase of your meetings to spend time on what that really looks like at Moat or at other places. I know Bobby Jones is going through some changes and whatnot, so I'd appreciate more information. But thank you for this today. It really helps to explain it. Thank you very much.
Shirley, one question. That's 3:30. You got to have an hour.
I don't care. I don't care. I've got more questions, and I'm going to ask them. Statements.
We have excuse me a minute, Shirley. We have another group of people that are waiting.
I know.
They're waiting to have an hour.
I can have
So
my
it's
10
one
minutes.
question.
5 minutes. Jennifer, I have a serious concern that you will be spread too thin to oversee what I think is an important job, taking care of this school, getting it started. When you've got your foot in up in Hillsborough, and you've got your feet over in North Carolina too, and Justin, who also is on this board of your management company, is still a principal up in North Carolina? I mean, I just don't know that I have concerns about you having the bodies on the ground here in Sarasota. Have any of you attended any of our middle schools or elementary schools that are giving our STEM programs? So you're saying you're going to give them more, but you don't know what we're giving them.
Well, I have kids in the schools. I mean, attending them as a parent or attending them.
How long have they been in our schools? And what grades are they in?
So my daughter is now in 7th grade, one of them, and so she was in Sarasota Middle last year and this year. My other daughter is now in Riverview. She was in Sarasota previously. My oldest daughter just graduated Riverview, and she was there previously. My son goes to Cardinal Mooney because that's a better fit for him.
You've got a former employee of Riverview High School listed as a board member. Was he promised any remuneration as a board member?
No.
Or position?
No, his background is actually in environmental science, and was the lead at Riverview over their
So there's no expectation of his employment with
No, he's still currently employed with Sarasota. He's not looking to be employed with us. He just believes in the actual foundation and the educational model. That's what his passion was previously to being that he was in environmental science.
I have a concern. We got to do this fast. I also have a concern about your education plan, and I'm looking on attachment C, pages 158, going forward. And it talks about that Project Lead the Way, but it seems like this is more of a high school curriculum that's here, and then you've got a K-6. I don't really see any middle school specific things in here, but again, maybe these are things you downloaded and in the hurry to pull all of this together, you pulled the wrong one. I don't know, but it
So
concerns
Project
me
Lead
that
the
some of
Way-
these things are done fast, and not all the details are there. Having Broward County on this, having Imagine on that, and having the high school curriculum instead of the middle school. It just, I understand what Project Lead the Way is,
Right.
but it looks like the attachments here are the high school Project Lead the Way, not the middle school, and then you've got some stuff about elementary, and I just don't know if that's a mistake. But I think that's about having too much to do in a short period of time, which is what's going to happen next year.
So are you asking me a question specifically to Project Lead the Way, or I'm not sure what you're...
Is this a high school program that
It's
you
not
got?
a high school program that we accidentally downloaded. We are starting off in 6th grade with one of the modules from Project Lead the Way. With Project Lead the Way, you can put it into any grade level of your school, and you are allowed to self-select which module you want to choose, whether it's middle or high school.
All right, I'll watch for that later.
Okay,
And then
okay.
the last comment I have has to do about the taxpayer of Sarasota County. When a student from another county comes in, their money doesn't come from that
Yes.
county. That money comes from our county. So Sarasota County taxpayers will be paying to educate students from Manatee County, and I understand you shut down your application in Manatee thinking, well, maybe we'll just bus them over here. And also our referendum dollars will go to those. Our taxpayers are protective of their dollars. And I have a concern as a taxpayer, too, that I will be educating kids, purposefully educating kids from another county that are going to be brought into a charter school that's going to target them.
Okay, so we are not targeting them. What I said is that in School of Choice now, students from other counties are allowed to attend other counties. There might be students here in Sarasota that actually also live in Charlotte County or Manatee County. When I worked as a principal in Manatee County, we had students from an at-risk community in Hillsborough County that took a bus 50 miles or so down.
So you aren't going to be marketing
We're
to
not
Manatee.
marketing to them. Our market is that 5 to 6 mile radius directly around where
so
the
that's
property
your market is the 5 to 6. You aren't
Right.
going to be marketing
We're
to
not
Manatee.
marketing there. What I said was there might be students from Manatee who choose to come here. That's why we didn't focus on that in the target area. And the shutting down of the Manatee, there wasn't really anything to shut down. We decided we wanted to focus here and not due to answer your question on spreading time or putting resources or efforts into other.
Thank you. I look forward to the final answers that you give to our staff.
Thank you.
Thank you.
One area that we have not covered, and that is ESE, where you said you expected 11% ESE population. Given the area that you're choosing to focus on, you're more likely to have 18 to 22% ESE students. There was one ESE specialist in the budget. The narrative says 2 to 3 positions, and there is no mention of a psychologist. So how are you going to work with all of these ESE students with one ESE teacher and no psychologist?
So the psychologist is actually included in the budget as contracted services. We would not hire an on-staff full-time psychologist. It would be contracted as needed.
Okay.
In the budget and in the narrative, we started off with one ESE person as like a lead facilitator until you actually do your enrollment and find out who your kids are. You're not sure if that number is going to be 11% like a district average or 14 or 18% as some might be in that specific area. I think in the budget and in the narrative, it talks about 4 positions that are called admin support. That's not secretarial or other support. That's curricular support, ESE or ELL, because you really don't know until your enrollment and your students are in exactly what you intend to serve. And I think that there was just language in there, because I do not write the budget, about hiring additional staff just based on exactly what your needs are and what those needs be, because you could have 18% students enroll, but the majority of them are speech and PT, and then those students are being contracted out. If they're all academic goals, then you need to have ESE teachers hired on staff in the school to be doing resource and et cetera.
I want to add that, if I may, Madam Chair, there's a note underneath the staffing table that says that depending on the number of ESE students enrolled, the number of staff allocated to ESE would also change. Also, with more students, you're right, there's an additional need, but there's also additional funding that comes in that allows us to hire these staff.
So I guess, have you included the extra funding for the ESE students you're expecting to come in? Has that been included in your budget?
Our process has usually been to be on the conservative side of ESE because of the budget impact, that if you project too high and too many ESE students, it increases your budget. We prefer to be conservative with a lower projection, knowing that with more students, more ESE funding comes in as well.
The other 4 positions, though, are there. They're built into the budget, and there's the narrative, because you don't know necessarily, is it ESE, is it contracted services because of what they need, is it ELL? I mean, in some schools, you don't expect a huge ELL population or what they are, and then you find out, oh, this is different
The
than we
section
expected.
where you're going is ELL.
Yeah, you just don't know.
As well as
I mean, you could
ESE.
pull a bunch of gifted kids, and they deserve services too, and so then you have to hire the right staff for that too.
I would like to thank you very much for coming today and for answering our questions. And it's a good thing you have a lot of voice in you because you did the majority of the talking. And it was nice to hear from all of you. But I recognize that you are the expert on this panel here. You are the one that really knows the program and also the application. So I thank you all for coming.
Thank you. Thank you for the.
Thank you very much.
Thank you.
Did I say it? Is that clear enough?
They all have pieces, but they're small pieces. I just wanted to ask her, are you going to be the principal? Is that your school? You understand?
I've got to have a 5-second break. Oh, is she closing or not? Yeah. Natalie? You know, you can't be talking at the same time. So we're not, Natalie's not closing anything, we're just stopped, okay. Okay. I sent an email saying I was shocked. I thought the numbers should have been reversed.
Sorry, everybody laughed.
I could understand
Have a
the
seat.
confusion.
It's not over.
Do you want to call recess? Seeing as there's only 2 of you. But as of now, we're still in session.
No, we're in session. They'll come back.
Okay.
We are not in recess. We are working.
Sorry.
It's okay.
A board member can't call recess on her own. It has to be done through the chair.
It wasn't a he.
It wasn't her, it was a
Next
he.
on our agenda, guys, is the 2018 Employee Group Benefit Insurance Rates and Fees. Mitzi Cochran and Lynn Peterson. Welcome.
Good afternoon. Good afternoon. And we like each other, but we have other guests who will probably be joining us, so.
Okay.
So, good afternoon. So since we last met to discuss medical insurance, Lynn and her team have been working, well, and me, very diligently to find ways for us to help curb some of our costs and increase and enhance some of our program offerings. So just kind of going through the slides, which are not in the right order. So what we've done, is for pharmacy spend, last year we told you that pharmacy spend was starting to kind of become a large component of our claims experience. And that trend has continued again this year. Last year we were a little over 27%. Now we're over 28% of all claims are related to pharmacy. So it is an area of concern that Lynn and her team are looking at to try to find ways for us to help reduce those costs. And it is anticipated that sometime during our next update, she will be bringing something to you that will hopefully help us reduce those expenses.
Hello, everyone.
Hello, Jade.
And then we also have been working to try to educate our retirees and those employees looking to retire regarding Medicare supplement plans, which is another option for our employees and retirees that will actually save them on the cost of premiums now that they're Medicare eligible.
Right. So for our retirees and employees who are headed into retirement, we provide them with educational classes to educate them on Medicare supplements, and how Medicare works with our plan. So if they were to take our plan when they retire, how it works with Medicare. Medicare's primary, our plan is secondary, and they have the option, being that they're retirees when they reach 65 for the Medicare eligible, to opt for a Medicare supplement. And there is a group Medicare supplement plan, obviously not paid for by the district. It is paid for by retirees. And that plan is an F plan, and we educate them on what that covers and how that works with Medicare, and the cost of that plan for an age 65 years old retiree is significantly less than keeping the district medical plan. Our current district medical plan, the low PPO, does act as an F Medicare supplement plan, but that cost doesn't change. So the current premium is $452 and change per month, and that is what they would have to pay, where the Medicare supplement plan is $180. So we educate them on, you're getting the exact same benefit, but you're moving over, and then that takes the retiree off of our plan and our claims expense. It's a win-win for everybody. So we're trying to just educate them so they know that, and we continue to bring in retirees who are currently on our plan to educate them that they have that opportunity. Certainly they can keep the district plan. We let them make the decision. We don't encourage them. We just present them with the facts, and then they go from there.
And then also for our wellness plans, Aaron's done a really great job under Lynn's guidance to expand the number of program offerings we have. We've also expanded and added free weights in our wellness clinic and a rowing machine. So who knows, maybe we'll man a district rowing team for next year's championship. So, and Lynn is continuing to work. She actually has a meeting set up with Ellery and Jody to try to locate a space for a South County or at least a mid to South County location for at least one other wellness center for our employees to use for their wellness offerings.
Have you looked at, as we were building the STC building, any available space there for this or not?
Not to my knowledge. And we're also looking at where the most utilization would be. So like currently the one is located at the landings because, and it was successful. We started off as a pilot, and the amount of employees that are based here plus the amount of employees that visit here allow that center to have the most utilization, and everyone in the district is entitled to it. So if you're from South County, you can get oriented to the wellness center. And when you come up for meetings, you can incorporate that in your meeting. After you're done, you can stop down at the wellness center. So this had the best opportunity to reach the most people, and we would continue to look at that for the next location.
So now I was going to turn it over to Lynn, and we were going to ask the gentleman from Arthur J. Gallagher to come up. They're the ones who did the medical feasibility study for our on-site clinic, so they'll be available to answer your questions.
So in an effort to obtain information on cost savings of operating a clinic, the district solicited 3 proposals from 3 vendors and ultimately hired Arthur J. Gallagher and Company. And they are currently present here are the representatives Joshua Rubik and Glenn Volk. So I'd like each of them to introduce themselves and give their background and their role in the feasibility study.
Welcome.
Kick it off. Thanks. So Josh Rubik
Make sure you lean into that one.
Excuse me. Normally I'm so boisterous at home, right, that it just carries fine, so appreciate that. I operate as a lead consultant with Gallagher, so that's working with both public and non-public sector employers on really ways to mitigate cost and provide sustainable benefit plans. The purpose of this study, obviously being an on-site clinic, is one of those tools that's utilized. So Glenn and I partnered together on the study to ultimately determine the feasibility of its effectiveness for your school or system.
Hi, and I'm Glenn Volk. I'm an actuary with Gallagher. I've been with the company 17 years. Large majority of what I do is with public sector clients. We do a number of these types of studies, have done a number of them, and I work with a lot of our clients who actually have implemented the wellness centers as well. So hopefully I have some background if you need it.
Okay, so I'm going to go through, you have the slides on the feasibility study. I condensed you have the actual report. I've condensed that to what I felt were the main items, and certainly Gallagher is here. I hope you don't mind that I refer to them, the 2 gentlemen here, as Gallagher. Sorry, shorten it, so I apologize. But Josh and Glenn can speak to it, and I'll be looking to them to speak to numbers because they generated those. But if looking at the feasibility study, there's 3 main components, and we're on slide 3, and they include the cost of operating the center. And within the cost of operating the center, there's the administrative fees for the vendor to manage the center. Some examples of the fees are the hiring of the staff, the obtaining insurance, communication services, reporting, maintaining systems, integrating data with the plan's TPA, and then there's some other things. So those are part of those fees. And then the other large cost is the professional fees to hire the staff. The other component is the potential reduction in claims paid under the plan, services provided directly at the center, and then a reduction in some unnecessary services that may have occurred elsewhere that the center maybe can redirect or have utilized at that center. And then the third potential savings is the improved health of covered members from wellness and disease management initiatives supported by the center, so incorporating that with the center, and improve productivity for the employees. So the data that was provided so that they could come up with their projections, it was 5 years of claims data from Florida Blue and 4 years of pharmacy experience from Florida Blue, the current plan designs, and the cost of drug testing and employment physicals. The data regarding the cost of operating centers was taken from Arthur J. Gallagher's experience with clients who have opened a center, and from their RFP and RFIs from the vendor had used involved with on behalf of their clients. And we also provided them with a complete employee zip code census so that they could look to see where if it would be feasible and where possibly. And on slide 5, the key assumptions that were used in the study were that the portion of the primary care medical service can be redirected to the center, and they looked at moderate being 20% of primary care being redirected, and then also the high, which referred to 35%. And then how effectively a center will serve as the gatekeeper for specialist referrals and diagnostic testing to reduce unnecessary utilization. And the third key assumption was the impact the center would have on future medical trends, incorporating wellness with the center to help affect claim trends. in looking at the slide on slide 5 is the cost of operating a medical center. They looked at 6 components, and the professional staffing costs, which were inclusive for a moderate utilization, about 49 hours per week, and for high utilization, again looking at having over 35% utilization redirected, being 90 hours per week. And each center would have an MD, an RN or a physician's assistant, and a medical assistant. And they would be looking at 3 visits per hour, and hoping for 80 to 90% optimal utilization of available appointments.
Can you please clarify who they would be employees of?
They would not be employees of the school district. They would be the vendor would have hired an outside physician and staff. The administrative expenses, as mentioned earlier, the vendor who administers the center charges a fee, and the fee covers the cost, as I mentioned earlier, the hiring, the reporting, the insurance, the communications, the transfer of the data to our Florida Blue or whoever is down the road, our TPA, and the drugs and supplies. The study assumes that the center would disperse generic drugs to take advantage of the unit cost savings available on generic drugs and promote generic drug utilization. And then the supply costs. And the rent that they took into consideration was $2 per month per square foot for one 3,000 square foot facility or 2 2,500 square foot locations. And other expenses that needed to be considered were license, insurance, cleaning, utilities, and probably some other, maybe laundry and that sort of thing.
Excuse me, so you're saying it would be based on 1 3,000 and 2 2,500, so there'd be 3 locations?
So if there was the study, and we'll go on to direct how that looks, they have if there was one clinic or if there were 2 locations, one north, one south. So if there were the 2 locations, they were talking about 2 smaller locations, like 2,500 square foot.
Instead of and, it should have been or.
Correct.
Okay.
Really, I just go real quick. You had mentioned, I think it was additional expenses were or were not included in the study.
They were.
Thank you. Important clarification.
And on slide 7, as you look, you'll see. Yes, I'm sorry, Eric.
Yeah, so you've said it a couple times, it'd be communications with the TPA. Does that mean that even though we won't be billing ourselves since we're self-insured and we will be managing the clinic, we will, in essence, be keeping track of what the cost would have been?
So, yes, that would all be under Florida Blue. Florida Blue has all of the reports on utilization, on what doctors our staff go see. I mean, we don't look at that. They can aggregate all of that data so that we know, like, say, Sarasota Memorial is one of our highest used hospitals. So all of that would go into their reporting.
So we would be able to see if this clinic had charged us money, this is how much money it would have been.
Correct. So we'll be able to see how many employees utilized that clinic and the cost savings.
The other thing that gave me great pause was the fact that they're going to reduce specialist referrals and diagnostic testing. I mean, if there's something wrong with me, I want to be able to refer it out to the cardiologist. If I need a test to find out if I have a tumor, I want you to do that test to find out if I have a tumor.
I don't think that's what they were referring to, say that they didn't want it, but I'm going to let the 2 experts here.
I'll be the actual reduction in unnecessary utilization of specialists, diagnostic tests.
Mm-hmm. Right.
That tells me that you're going to reduce the number of referrals to specialists and reduce the number of diagnostic tests that if another than what our people are getting now. That's certainly what it implies.
I think it would be, and Glenn, feel free to jump in. The intent of the of that aspect is referencing if we're able to lower the cost of care, so the barrier of entry to the employee, i.e., in this model, free, right? So you can't get better than that. The reduction would be there's often people who self-refer out. Well, I kind of feel funny, so I need to go see this specialist. So there's a fair amount of, when you look at any report out there from whether it's, I think, congressional budget or any of those, there's a significant amount of part of the healthcare system that's just due to waste that's out there. So the intent in the reduction wouldn't be that we're going to put in higher amounts of prior authorization or pre-certification and put more stringent use on diagnostics, but rather that they would be reduced simply because people aren't getting bounced around the maze like they otherwise would be if they were to self-refer. Now, there's certainly some folks that self-refer and are doing so appropriately because they have a relationship with their specialist, but certainly there's a component of that that's just waste just from lack of knowledge, and by reducing barrier to entry, there you're able to get more people to come to the clinic.
So there won't be a copay. Is that what you're saying?
That would be up to you all to decide, but as a general rule, we see that either very reduced and or free.
Okay. So we're on slide 7 with the summary of expenses, and all of these numbers did not come from me. So if anyone has any questions going over all of this, I'm going to let Joshua and Glenn speak to those.
Jane?
The cost for rent.
Yes.
Would that be in line, Mitzi, with our using one of our existing buildings? I know we have to build out, and that was estimated to cost $50,000 or something like that. But how would that comply with these costs?
I actually, as far as the rental piece goes, I actually had our real estate agent who locates properties for us just kind of do a random, is there a 3,000 square foot medical facility available? And the annual rent on that, including taxes and insurance, was about $78,000. I think their estimate's $75,000, so it's pretty much right on the mark. It's our hope, though. I would hope that we have a facility available that we already currently own. Again, what I would love for us to be able to do is maybe find something near the STC campus and incorporate those students at the schools and the CNA programs, the nursing programs, the medical tech programs, be able to maybe come in and get a little bit of experiential education opportunities there at the clinic sites if we were to open one. But again, it depends on what will work best. Maybe somewhere, a facility closer to the interstate would work better. Those are things that are still unknown. But yes, I think that the rental rate, should we have to lease, is pretty much right on the money.
I agree. The rental rate is pretty much on the money. I don't know if you guys know, I'm a CPA in Venice, and one thing we have in Venice is a lot of doctors, because we have a lot of people who like to go to a lot of doctors a lot. And so I'm shocked that you're going to be able to find a I'm sure it's not just one doctor, even though you said a physician. I think you meant plural. There'll be multiple physicians. But getting enough part-time physicians to work 49 hours a week for, essentially $295,000. That's, from... No, well, the MD. No, the MD. The MD is $295,941. Right. I understand. It's a conglomerate of people. It's a collection of people. It's multiple people but getting enough physicians who work 49 hours for $295,000. Maybe that's how it is in North County. They get that, but in South County, which I thought the income would be cheaper, that they're going to be utilized enough that they're going to be able to bill $1.2 million, which is rather aggressive. So again, I do monthly accounting for doctors. $1.2 million in utilization and getting paid $295,000. You're probably gonna have a high turnover of doctors. See previous conversation about the charter schools.
If I could try to answer that. I mean, generally the way these deals work, the physicians are signed at hourly rates. The vendor will go out and contract with the physician. So it's not the normal fee-for-service type reimbursement that would you'd see in the retail market.
No, I have a client who does this at Health South and at the hospitals. I have 3 companies of clients who go out and do this per diem rate. So I'm extremely familiar. And nausea, almost. Yeah. But I'm just shocked at this rate. I'm still shocked at this rate.
I mean, this this is what our other clients have in their agreements. I mean, generally the hourly rate for the physicians runs $200-$250 is what they will do, and it's typically not your. It's a physician at a certain stage of his or her career that is most interested in this kind of thing. It's people who are ready to get away from the churning that they're doing.
But $250 an hour, 49 hours a week times 52 is more than $250,000.
I mean, I can recheck the.
Yeah, I can do the math. It's more than that.
But it's
almost double that.
Well, but let me.
It's double that.
Is there a question in there, Eric?
Yeah, I'm trying to understand where it is they got the data from. Because if it's $250 an hour, what he just said, if you take $250, just assume it's 40 hours a week, 2,080 hours, $250 an hour at 40 hours a week, which is less than 49. 40 is less than 49, is $500,000. So my question is how'd you get from $500,000 to $295? And he just the one who just said $250 an hour.
And I clearly,
you understand my math? We agree on my math?
No, and I should have looked at the.
Is my math correct?
Your math is correct.
Okay.
The hourly rate that we had used was 120. I mean, it was based on agreements that we see. So I apologize for that. And that is what drove the difference, yeah. I mean, but it sounds low, but that is.
Point of clear.
So it's not $250 an hour for a doctor.
It's 120.
It's 25.
Wait, so can I just stop for clarification? So it's 120 an hour versus the 250.
That's correct.
And to go to Mr. Robinson's point is that I think that the turnover rate, and I'm not sure from that medical profession as far as what they see out there, but as he stated, he may do the books and see what their incomes are. So the likelihood of the sustainability, I think, is what I would be concerned with, is if in just in general, one, the usage, and then is that hourly rate competitive? Would that be inclusive here? I mean, it was a regional poll? Is that how it worked as far as you coming up with the cost per hour?
It's taken from our other clients that have these types of arrangements in place, and it certainly will vary by market. But this is typically what we see. If it's, and I mean, first of all of these numbers are projections. The only thing I can promise is every number here is going to be wrong. I mean, when you go out to bid, and if you do that, we're going to come back and everything is going to look a little bit different. So that's fine. If we're off, I mean, yes, it might be a little higher. It's not going to change the conclusion, I don't think, that we're going to come to. I think one of the things that always surprises me when you do these exercises, you think we're going to open a medical facility, the biggest cost is going to be the cost of the medical professionals, so the physician and the others. When all is said and done, that's really not what we see. It's the administration of the facility that actually costs more. So, and certainly we want to be as accurate as we can. I'm not saying that's not important, but I think if there's variation in there, and perhaps there is, it's still the order of magnitude is just not going to change that much.
Shirley?
I think where you'll see the big difference is what you said. It's that administration that isn't going to be needed. That doctor isn't going to have to be filling out all these claim forms, is not going to have a big staff, isn't going to have to be paying all the other costs involved in running a doctor's office. I was recently, through my husband, referred to a chiropractor that will charge you $50 a visit. Won't take insurance. And I'm thinking, geez. And then I look, well, I could pay $40 for an out-of-plan doctor, or I could go to one that I know I can get in, not have to wait. He's got one person in his office who answers the phone and sets the appointments, and you don't have to stand in line and wait. And they will also refer you to an MRI for $150 if you're going to pay cash. You look at it, geez, $150, or should I pay my $250 copay? I mean, I would hope that we would find people like that we could partner with, that we could do those things, that for getting rid of the paperwork and all of those insurance reviews and everything that comes with them, will do services for a certain fee, that we could look at that. I also, from talking to, board member Lee Swift and touring their facility, that what you get is you get a lot of people, you want them to come in and get their annual physical. Basically, you want them to get, what is your blood pressure, what are your blood counts and your levels on this, so that if we see somebody whose cholesterol or triglyceride levels are getting high, they're not showing any symptoms yet, but they got a high level, so that we can start them either on medication or you refer them to another physician that's going to oversee that, but yet you're going to come back and do the regular steps of having the monitoring, making sure that their blood levels are coming down, and then when they need to, you go back to the cardiologist. Is that what, that's what he was saying, this is what you would do. Because I know I went to my physician and I was sent to 5 different people to look at this, and this, and then they monitor and get these blood tests and see how things are running. And so I would imagine that's what this would do, the blood test. But they also said the major savings that they're seeing, besides the costs of those routine tests, was also some of those routine prescriptions for diabetes control and for the cholesterol control. The cost of just getting those medications that so many people are using, the savings was, well, I won't say astronomical, but very high. Just getting those prescriptions that so many people are on these days. And then monitoring that. Is that more? We're not going to. If somebody has a gash in their arm, we're not going to treat them. That's not what we're here for. We wouldn't be here for. That's not what it's for. It's for more routine things. We'd probably put a Band-Aid on them and send them to the hospital, right?
Right. And you're correct. We are looking to, one, attract, even if the current healthy who go to see their doctor or even have a chronic sickness, they see their doctor. We're looking for those people too that aren't even going to the doctor, and then they're the ticking time bomb because they've ignored everything for whatever reason, whether it's cost or they just don't want to know,
or don't have the time.
Do we
know? We've been offering employees, I don't know, was it $50 or something?
Yeah, that's the prevention.
If you go, the prevention, if you go and you're signed up and you've got your regular doctor and you get that annual physical, it's a rather low number of the employees that are actually buying into that, isn't it?
20%. Yes, it's about 1,000 employees that.
But I can tell you, I have mine and I never remember to submit it.
Right.
So I don't know how many of me there are out there.
There's more. We've heard from them.
Yes, you can.
I didn't think board members.
There's another 80% of you.
But I do believe that a big portion of opening a clinic is to attract those individuals who do not see a doctor at all. They either
and then end up going to the ER when they have a cold.
Correct.
Right.
Or it's gone to a whole other level of right, and that's a very true statement.
Okay.
Your turn.
I want to go back to the numbers because I understand you're doing projections, and you're exactly right. The only thing about projections is they won't be exactly right. So a year from now, we bring you back and say, we've had a clinic operating for a year. How did we do? And so, calculating the clinic expense, that's pretty easy to track.
Absolutely.
It's the direct savings. I want to know how that calculation works a year from now, in which we say, well, how did we do? How do you make that calculation? Is someone literally saying you didn't do this, this, and this, and it would have cost that? Or is it more sophisticated and actuarial?
Yeah, our standard approach, and we get asked that by all of our clients who operate the centers, we'll get detailed utilization. So we'll look at the number of office visits in the last couple of years before you put it in, and how many in the first year with the center. How did that change? Other types of services that we think can reasonably be affected by the center. How did your prescription drug patterns change? Did the generic rate, actually it'll go down because a bunch of drugs come out of the health plan entirely, and it makes the drugs in the health plan, the mix different. But you'll have, if you add in the piece that's going through the center, overall you'll see a much higher generic use if it's working properly. So our approach is really to look at the actual service level utilization and how did that change, and that's still not perfect. I mean, those things will fluctuate even without a wellness center, so it's not by any means perfect. The other thing we'll try to do is look at the health risk of the population. As we said probably too many times in the report, the real key to this thing, whether it works or not, is whether you do affect the health of your population. I mean, just shifting people into the clinic, maybe you break even, but even that's hard. I mean, it takes a lot of good things to get there. But if you can legitimately get more people engaged and get their health improving, then you have a chance to see some savings. So we do have measures where we can measure each individual can have a health score based on all these different algorithms that are available. Is that changing the way that you would hope that a wellness center would help it? So
follow up if I might. And so, although I'm not a practicing CPA, I did study accounting, and one of the things I know is numbers in parentheses aren't good numbers. Okay, and so when I look at projections, I see numbers in parentheses, and you made reference to a break even. Is there a projected break even point in year 2 and 3 in which clinics pay for themselves or deliver savings to the district?
Yeah, so I can address some of that.
I see the way you're looking at each other
as well. Yeah, so on the summary of expenses, when we have to your point, the bad numbers or the numbers in parentheses, if you will, it's predominantly using a primary care replacement type model. So the point that we're trying to at least allude to in here is simply using the clinic as diverting primary care visits that would occur out and bringing them into the clinic is going to be hard pressed that ROI. So our approach and the goal, and we working with your team here, would be how do we take the clinic and use it as kind of that patient-centered medical home, and that folks will continue to come back and then measure the health risk score. So some of that's going to be due to your comment on, or someone's comment on, well, what does it cost to go to the clinic? So if we keep that free, we're going to drive up utilization. And then the other component of that is, what are we doing with the primary care or specialist visits outside of the clinic? Meaning, if we're giving this free visit or free opportunity to employees, do we also in turn have the ability to perhaps increase a copay $5 here or there to drive up utilization from that end? And the whole point being, the more utilization you're going to get, the more the quicker you're going to get to your ROI. So to, I guess, directly answer your question, there we would typically see some type of ROI, and Glenn can tag on and run I'd say year 3 or so, because it's almost like a wave. The first year you're going to get some, and then more people are going to talk, and there's going to be some potential, I'd say, skepticism at first because it's being offered by you. But a lot of that comes down to what's the communication strategy that we put in place. So Lynn and team and we've had conversations on what's the right way to do that. Do we do focus groups beforehand? Do we do surveys? How do we do this to where we're building trust while we're ultimately rolling this out? Because unfortunately, to a certain degree, if you build it, they will come, but they may not continue to come back if it's rolled out poorly. So that's part of the other component of this.
Bridget.
And that part, and I know it's really kind of restructuring pattern behavior, if you will, and there's a financial way to do that. And I would say ultimately, I know I saw facial expressions and I cringe to think that we would have to be doing that. So, but I do recognize there's ways to do it. My concern is when I visited other public entities, clinics, and I compare it to my general practitioner's office, it feels like it was missing a lot of things that you would usually see. Now, and probably because we don't need all of those things, and certainly I don't think that cost to have all that equipment brings in a whole nother realm of impact. So how do we, just from the staff standpoint, having them visit those, feeling comfortable to visit those clinics, and then making sure that they have the facilities or the right pattern for them to go to the next step. That to me is that breaking point that I think is going to be the biggest challenge. But and the ROI, if I read through the conclusion here, as it says, it would be difficult to get center utilization high enough that the pure direction or redirect of services from physician offices to the center would generate significant savings to SCS. That's not what I want to read and have a conclusion when we've been talking about this for some time. That's not you. I mean, that's the data talking, so I get it. But so I guess flipping over to you, where does this leave us?
Well, that is all. That just means just pure redirection. So you have to have other things. So you have to have your wellness. You have to really promote that. You have to have a strong marketing campaign and promote it to the employees, testimonials, that sort of thing, to really give it a positive experience for everybody. And if they have a positive experience, they're going to tell everybody.
Eric?
Conceptually, it sounds like a good idea, but the problem is the more and more we get down in the weeds, a lot of things give me pause. And so one thing I would like to see if we can get from other school districts in Florida, how they handle what's their P&L look like, what's their utilization, and the other thing is, having these negative impacts, because we're self-insured, we have a duty responsibility, fiduciary responsibility to make sure that we have a healthy fund. So when I see things that are negative, it does make me cringe. And I also want to understand, what other things down the road would this probably end up entailing, like raising the copay of everybody else. Those type of things, you should have seen the expression of everybody around the table when you said that. Ms. Ziegler said. But I want to know what other things that may end up being a consequence of this decision. I want to go into this eyes wide open, and so I want to understand what am I looking at. And we may say, look, we understand we're going to lose money, but our employees will end up being healthier, and so we weigh the two, and we say let's go to it. But I need to understand truly what it is that we're going into. I think that some of the assumptions here, if they go a little bit the wrong way, that negative number could get greater very, very quickly if you don't get that utilization, if you don't get that drive down there. And so that gives me pause too. Because that's very well possible, right? So I would like to know, how do other districts, how does it financially work with them? I'd like to know what other consequences may come as a result of this decision, and possibly maybe doing a what if scenario. What if we're off 10%, and how many people are going to use this? What does that look? Or what if we get 10% more? What does that look like? I mean, I want to understand, what we're talking about. Because if it says, hey, if we're off 10%, it's going to be catastrophic. That's going to be, I think I'd like to have that information to make my decision. Do you understand what it is I'm asking?
I mean, to be clear on if we're off 10, you want us to bookend it even further, right? Right. We're doing 20 and 35, so for example, we'd be doing 10 and 45. If we were to bump it down 10, bump it up.
Right. I just want to see what ifs. I mean, are those unreasonable requests?
No.
Okay, so I just want to make sure I go into this eyes wide open. Yeah. Conceptually, this sounds like a really good idea, and maybe we may put the money aside. I won't, but maybe we do. But I just want to make sure that I understand that.
Bridget.
But real quick, though, and I think this is important, we said, I know that's a culture, we have to, this has been a conversation we've been going through for many, many years, and figuring out the right timing to do a number of things, but we have certainly tipped our foot into this, and we're, I would think, committed to it. But I like his contingency, looking forward, so it's not, oh my goodness, we weren't thinking of this. And so however we frame that out, what other districts or other public entities are doing, we've talked about this in the past, sharing facilities with other municipalities or other, the county. I don't know if we've really ever dove into that from options. And so I guess, and even if you have, that's something I know that historically we've talked about, and I would like to see, you want to make sure that we're not narrowly saying, this is the way everyone's doing it, these are the only options. I think there's a lot of cost incurred. I think the culture standpoint, that's its own beast in of itself, but I think the facility and those other additional costs really come to play of weighing the overall impact of it being beneficial. And I think it takes some time to really change that culture. And I think time and time again, based on our size of our enterprise, I don't see why we wouldn't be able to do it. But I know there's a lot of risk but I just want to see different options. I think to his point too. So
right, it's the risk versus reward.
Right. No, of course.
Again, we have agreed to assume all of the risk for being self-insured, and again, in order to help mitigate some of the risk, which is to increase utilization, because we have a large group of a large set of our population, I believe, who don't ever go to the doctor. So if there's at least an avenue, then we will see greater claims technically because they're actually seeing a doctor, but the hope is that it isn't the catastrophic claims. So that is one area that we'd like to look at. And another area we'd like to look at is we have spoken with Charlotte County, and I've spoken with their vendor, and we actually went to, Lynn and I went to a conference in Vermont, and Brevard County Schools was there, and another school district was there, Charlotte. I thought there was another one. Anyways, and we know that Manatee County is contemplating opening clinics maybe with the same vendor. So there, to me, is a wonderful opportunity for us to do an interlocal among 3 school districts where because we have staff who live in Charlotte County. Charlotte County has staff that lives in Sarasota, and same with Manatee. So, if you can capture the south end, even for our Northport residents that live in Sarasota to go there, and our North County residents to go, there's a lot of opportunities there that could help to offset, and that would be a great partnership for us to look into also. But,
And if I can add that the city of Sarasota just signed a contract with that same vendor that's at Charlotte, and I know that the Sarasota County government has been calling and asking me questions, so they're looking and exploring that too.
Lots of opportunities there for us to.
You were talking about if we were off by 10%, and they've given us some fees on moderate utilizations and high utilizations and low and high. So you're saying you want that expanded even more than just
because those deal with if you're going to have more than one location, which 2 locations. My issue is you have a location and we don't get the people that's expected. What impact is that going to have on us?
I know another issue that was, according to Charlotte County, a benefit to them was that there wasn't that long waiting line, and I know. In my own family, my daughter will have trouble going, and she's supposed to be getting blood tests, before she gets this, and that, but it's a problem getting all those blood tests and going to the doctor and because it's difficult for her to get an appointment after school. Mm-hmm. Or it's difficult for her to get an appointment and then get there and back and all of that. And I understand that, a lot of the employees actually will do it during their lunch hour or something so that they can get in, get out, which is one of the big advantages of a program like this, is that we do have the ability to, not what doctors' offices do where they stack the people. We'll plan 3 people in an hour.
Exactly, and that's exactly it, so that there is no waiting, so that the employees can get in and get out and get back to work. You have total control over the hours of the facility, whether they be open early to help our maybe bus drivers who go in early, maybe need to go in beforehand. You have that flexibility of having them later hours.
I think there were some early hours and some late hours that the facility
had. So you control all of that to have that flexibility for your population, so there's no wait.
One of the things that I'm surprised Mrs. Ziegler didn't mention is children. And, having younger children, they're not normally covered in a clinic like this. Are there any that do have facilities that cover children? Or is there a certain age, like when the child gets to be 2, or I can't remember exactly how that plays, but.
I can address them. Glenn, you can jump in. We typically see probably lower utilization with them because you generally have a relationship that they're going to have with their pediatrician. So, and I can tell you, myself and my wife, we have a good relationship with our pediatrician and would likely keep that up. I think, is that addressing what your question is that are we going to get a utilization from dependents?
Well, there might be a flu or there might be a slight cold or something like that it might be a whole lot simpler to get. And there are some pediatricians in this area that have an open office hour between 8 and 9 every morning, which is, I think, very helpful. But I'm looking at other ways of getting people involved. Do we actually have any data on how many people don't go to the doctor? Have we ever drilled down and done that that piece of it. How many people are, and using the emergency room is another kind of a no-no, but do we have any ideas of how many people are not being?
I can get those reports from Florida Blue, how many people have not utilized their plan to go to a doctor. That is definitely something we can get.
Todd?
Talk to me about the relationship with your primary doctor. And you had talked a little bit, we're targeting people who may have a primary but haven't seen them in years. And so let me just ask the question directly. If I had a private practice in town, should I feel threatened in any way that the school district is contemplating opening up a clinic? And so talk to me about that relationship. Does this become your primary care? Are we encouraging employees to, quote, drop their doctor and come to the clinic?
No, we're not encouraging them to do that. Certainly that is their option, to keep their primary care. If they're happy and satisfied with the services and that they're getting, that's fine. They can also use this facility as a walk-in sick. They can't get into their primary care, but they're feeling ill and they need some antibiotics or whatever it is. That's their option to walk in and get taken care of, so they can use it to supplement what they already have.
Bridget?
Are there, this is kind of going even deeper, but, I know there are firms that self-insure that do biometric testing and such like that to do an additional decrease on their, is that something we're looking at? And so, because ultimately what got us thankfully here was on the cost increase that would be whether or not we are approving that. And so obviously we're working to ensure that we don't have an increase in medical expenses for our employees and staff. So my question is that something we are looking to implement from, when you do the biometric testing? It's another way, again, changing the behavior, having people go to those locations. But in one company, as an example that I'm aware of, you get a discount on your rates. So is that something we have talked about, looked at, thought about?
Well, we haven't. We give the prevention pays as an incentive, to get people to go and just see their primary care to see if there's any problems. There have been discussions around it's an option to do, just like there's an option to charge smokers more. That's an option. There's lots of options out there. It's whether or not you want to really do that, because the biometrics to require that is you get into a questionable area when you start requiring that.
Oh, no, and it wouldn't be required. It's the benefit of if you choose to follow the path. I would not say required.
It's the carrot versus the stick concept,
right.
Yeah. So.
But I do. Where is it going with that? But you raise also a good point. There's a myriad of different options of what to look at. Who is helping us? Is that where you guys come in from, the various options and the cost benefit? And
we have that, and we also Aon also helps us look at various options. Whatever we choose or want to choose to do in terms of those types of items, they become a point of negotiation.
Okay.
I have to tell you all that we do have another piece that needs to be discussed tonight, and we have to break down around 5. So if there are no further questions.
Okay.
6:30 start time. We got
5:30, excuse me. So if there are no other burning questions, can we move on to the next presentation?
Sure. Thank you, guys.
Okay. Hearing no objection.
Thanks. Thank you.
Okay, but do they know that we're still here?
Yeah, we're still here.
Okay.
What's the next one here?
Thanks.
So I'm going to ask the folks from Aon to come up now. It's like a room full of suits.
You certainly made an impression when they came in.
That was quite the contingency, huh? So I think most of you know J.R. Shamley with Aon, and next to him is Paul Booten, and he's the newest member of the Sarasota County team with Aon. So I'm going to let them go ahead and kind of give us a little bit about their background real quick.
J.R. Shamley, and I have been fortunate to work with Sarasota Schools since 2004 as your actuary, as well as your account exec for strategy. I'm part of the U.S. Actuarial Operating Committee for Aon, and have been with Aon since 2004.
And hello, I am Paul Booten, also from Aon, out of our Tampa office. Healthcare actuary by background, have been with Aon for over 10 years, and am the newest member to the Sarasota School Board team from Aon.
Okay, thanks. So if we can go to slide 12 from the presentation, this is just kind of a brief history of our rates that we've had. Back in 2011, we had a double-digit rate increase, which caused us to then renegotiate plan design. There was quite a bit of, we had special committees and the Financial Advisory Committee, and so we had a lot of different groups working on it. We made quite a substantial number of plan design changes, including adding deductibles on our HMO plans for emergency room visits. That was one area we saw a lot of redirection by doing that, which was great. And then we sent our plans out to market, yielded us a great savings of like 8.9%. We had great claims trend the next year, and we were able to get another 2% after that. But then we returned right back to those same levels as is expected. So we were at 8.7, I think, and 8%. And at that time, that was when the board was like, what are we going to do? We have got to stop the bleeding, basically. So we investigated with Aon's help to go with self-insured. The Financial Advisory Committee did a lot of work on that, and it was great. We made the decision on January 1st, we went self-insured, and we've seen much lower increases because of that. And this past year, 2016-17, was phenomenal in terms of claims experience. In actuality, after the first 3 months of being self-insured, the underwriting was showing that we needed to increase the rates for 17 by 7.54%. After 6 months, they showed that we needed to raise our rates by 6.4%. And those all took into consideration, again, the repayment of those funds we borrowed to meet the state reserve requirement, because there was a 3-year repay period. So based upon that 3-year repay period, those were included in those assumptions. So I said, we need to extend that because I don't want the rates to increase by that much. So we extended the repay period to 5 years, and that allowed us to have the rate increase be less than 4%. That less than 4% was still great, because we still ended up coming in about $5.5 million ahead this fiscal year. So even though we were trending one way, we ended up going the other way in this past fiscal year, which is good news for us. So,
Mitzi, I don't want you to get too far away from your comment that we, quote, borrowed money to establish the reserve. Can you be a little more specific about that?
Sure. The state has what's called Florida Statute 11208, which requires a self-insured entity, a governmental self-insured entity, to retain 60 days worth of incurred claims, as a reserve, so that in the event you chose to not be self-insured, you'd have enough funds adequately set aside to be able to pay out, please correct me if I'm wrong, but to pay out your claims that have been incurred to that point. So that's a state requirement, and you have to have that in place within the first 12 months of operation. So that's been a lot of school districts' biggest concerns about going self-insured, is having that money available to them after the first 12 months. We had a fund, the escheated lot sales from the Northport escheated lots, where the county generously shared dollars with us, sitting in a capital fund to be used at some point in time, but it had no restrictions on it. So to us, it was also almost exactly 60 days worth of incurred claims. So that was the funding source we used to establish our self-insurance fund, to have enough money to meet the reserve requirements of the Office of Insurance Regulation, and then with the plan to repay that capital fund at the end of 3 years, and then at the end of last year at the end of 5 years, and then after this year's great returns, hopefully back to 3 years again. So that's where we're at with that. So on page 13 is just some other projected rate increases. Lynn sent out through FIRMA a survey of other school districts on what their rate increases were. We received some others, but we only included in here other self-insured entities just to get an idea of what they were experiencing. In addition to that, I was looking at Pinellas County. They went self-insured the exact same day we did. So I just was curious as to how they've been trending. Now, again, different population, more employees potentially, but maybe older employees or less healthy employees. But their percentage increases in 16 were 6.45%, and 17 were 6.2, and they're projecting 5.2 for 18. So they're pretty steady, but it could be because they're funding their 11208 also. So it could be that their percentage increases are a component of the 11208 also. Don't really know. Charlotte went 5 years without a rate increase. When I spoke with their CFO for their 17 year, they were at some point looking at maybe 20%. So whether they did that all in one chunk or not, I'm not aware of for sure, but they answered and responded back that they were going to be doing 9% for this coming year. So there are quite a few out there. And you can, as you can see, pretty much most of all of these plans do require some form of employee contribution. So I just wanted you to see that and be aware. So pages 14 and 15 are pretty self-explanatory. It's just basically our financial statements. The first column was after our first 6 months of operation. The second column was through June 30th of 17, so those numbers are not audited yet. We haven't completed our audit, but as you can see, that's where the $5.5 million is coming in. 2017 column 3 is Aon's projection of what our plan year will look like. Now their projection doesn't take into consideration our investment income or the staff salary and benefits, but those two amounts pretty much offset each other. So I think we're fine with those projections. The next column is the 17-18 budget that you guys approved last month. And then the final column is Aon's projection for 2018 and where we will end up. This does take into consideration the positions that were added to the budget in 17-18. You know, we increased the staffing levels, so those have been added into those numbers also. And the budget was prepared with the anticipated 1.9 or the proposed 1.9% increase that is going to be before you guys this evening. And I just did want to talk with you quickly about that also. I just wanted to let you know that it's not just the medical insurance. We're talking about that right now. But in addition, the life, disability, long-term disability, and vision insurance plans are coming to you for those rate approvals. There's no change. They're all under a rate guarantee for 2018. And the dental has no premium change for 2018, but there is a 10-cent per employee per month increase in the administrative fee to Delta Dental. That's just being absorbed by the fund. There's more than adequate fund balance in that fund, but I just wanted to let you know there's an increase in the administrative charges for Delta Dental on the dental. So the medical is the only one that there's a requested rate increase on for premiums. And so again, on page 15 now is the 11208 reserve requirement. So as you can see in the first column, the second item down is the transfer in from the Audited Lots Fund. So this is where the money came in to fund the reserve requirement. And then our operating gain or loss. So we had total funds available of $8.5 million. The reserve requirement was $6.7. So we had excess funds of $1.7 available to repay the $6.8. So there wasn't enough available. And then the next year,
Did we repay any that year?
We have not repaid anything yet.
Oh, I thought she said 6.
Because there was 1.7, which is less than a half a month's worth of claims and excess funding available. So for the fiscal year that just ended, we had the 8.5 from year one, the 5.5 from this year, so we had $14 million available. The reserve requirement was 6.7. So there is available funds to repay the amount we borrowed in full as of June 30th of this year, but it left us with the $510,000 in the account, so I wasn't real comfortable going ahead and making the repayment now. So budgeted for 17-18 is a $3.9 million surplus. So the reserve requirement is just under 7.4. So there's more than enough money available to repay the fund. And there's $3.8 million, or just about 1 month's worth of claims experience left over in that fund. Those dollars can be used for the upfront costs of a clinic if you'd like to use that. I just want everyone to keep in mind that this is just about 1 month's worth of claims. And we did have a hurricane that went through here that took a turn to the east. Had it not taken a turn to the east, my concern is that this 3.8 would have been eaten up in no time in claims from our employees and their families.
Bridget.
Which brings me right to my question, because as we know, if even the state requires the 60-day reserve, what is best practice? Because we don't always just go on the bare minimum. If you look at where our threshold is 7.5 here in the internal policy, to your point, I mean, I don't want to be a padding fund by any means if it can have an impact on our employees at that time. But there is a balance. So I'm just curious from your experience, because health and benefits is not my area. So is a 60-day, when you see to your clients, is that what you recommend, or is it just because it's the state bare minimum?
Great question on that. It's clear that you need to have a minimum of that 60-day limit. The $500,000 definitely would concern me in terms of the volatility. The last thing that I would want to project and put Sarasota schools into a position is where there's a required contribution as we go forward. So I would say that a 30% margin on that is a safe area. Others have gone tighter. I have seen where they've been to the dollar on that in those limits. This is where the fact that I'm an actuary may come out, where I'm a little more conservative than that. $500, I would strongly, $500,000, I would strongly recommend against that is below a reasonable threshold. Remember, we are talking about, $45 million in claims, and there was a question earlier about plus or minus 10%. So think about that, the $4.5 million differential in that, in terms of those swings that are out there. What you can you won't be relieved of this 60-day limit. So at some point in time, if this gets below that limit, you will need to come up with other funds to be able to satisfy those limits. So my recommendation would be to have a margin on there, and a 30% would be a reasonable limit.
And so, again, the plan was a 3-year repay. This is 2.5 that we're actually looking at. So, by the time we get halfway through the 18-19 year, there may be more funds available, so that after we repaid, it would be more than a month. And nothing says we have to pay it all back at one time, or, all in one fell swoop, and or within 3 years. I was just trying to, when we were looking at what the rates should be, the recommendation originally from underwriting was no rate change at all. And my concern was, we were talking about wanting to open a clinic. If we don't get the utilization, that 10% plus or minus, and especially year one, you didn't promote it well enough or whatever, that it's $1.6 million to operate it. So $1 million, I'm hoping we get at least $600,000 worth of claims diversion. So $1 million, which is what the 1.9% yields us, is kind of where I was going with the 1.9% increases. If we wanted to open the clinic, if we didn't, it still left us with enough of a margin here, or we don't repay it all at the end of June. So there's some flexibility. Right now we're sitting at 10.6 million. So there's flexibility in that number.
we'd repay it, it would go back into the capital fund, right?
Correct.
Has the capital fund, or the capital plan at any point shown where they're going to use these dollars? I mean, it hasn't been included in the capital fund at all, has it?
No, it wasn't included in the capital fund, but as you know from our capital discussions, there was a discussion about wanting to borrow some money. So, I mean, it's not that the 6.8 would offset the need to borrow to build a school at the current point in time, but it could help the fund, overall.
And it could help purchase the property.
It could help purchase, yeah. And I think that that's not necessarily a bad idea.
The purchase of the property is still in the budget. The 2.5.
There's, right. But I mean, more property for future school sites, yes. So.
Any other questions, Todd?
And just remind me again, the difference between carrying forward rates from last year and the 1.9% is $1 million?
It's just shy, just about one point.
It's like $1,025,000 or something like that?
Yeah, it's just over $1 million.
Gotcha.
Any other questions?
Bridget, you look very concerned.
Thank you.
Okay.
Thank you very much for coming.
Thank you.
Greatly appreciate it. Sorry you had to wait.
It's on the...
Good job, Mitzi.
It's on tonight, yes. It's on your agenda for this evening.
Lynn's going to lock the door. Nobody leaves tonight without health insurance.
That's right.
Yes, Lynn may make you stay and make a vote, please. But she's like, no, we're trying to keep it on the same day.
Open enrollment Christmas party. I think we're going to PDQ. I think that's what we're doing.
Our workshop is closed. We will be back on the air at 6:30 tonight. Thank you.